All right, thank you. Good afternoon. Once again, everybody, welcome to the January 15th meeting of the Financial Technical Advisory Committee. I am Mary Franzen. This committee supports the work of the Universal Healthcare Commission. So I am going to turn it over first to Ross Valori, who will call the meeting to order.
Thank you, Mary. Welcome all. It's now 2:03, and I call the January 15th meeting of the Finance Technical Advisory Committee to order. Happy to announce we have some new faces here today, along with some familiar faces. I'd like to just quickly introduce, and then we'll ask for a little bit of an introduction during the roll call this morning. Hiroshi Nakano and Sarah Hulling, two new members who were approved. During the December Universal Commission meeting. We are very excited. We also expanded the membership numbers for FTAC. I believe that went from, Mary, correct me
From
if I'm wrong,
nine to 10, nine
not
to up to 10.
9 to up to 10. So really excited to have that extra capacity and knowledge that we rely on so much with this group. So really excited about that. And second, Pam McEwen will once again be stepping into the role of FTAC liaison. In that job, maintains communication between the Universal Commission and FTAC, frequently provides updates to the Commission and then to FTAC about the Commission's work. And so really grateful for Pam for taking on that role and the time and effort associated with that. Greatly appreciate that, Pam, and thank you. Next up, I'm going to run through roll call. When I call on you, please unmute and let us know that you're here. And I'll
Okay,
start
hold on.
off with
Actually, Ross, I
Sarah.
want I want to jump in
Oh,
for
go
just one
ahead.
second. Sorry. We are trying to move all of our FTAC members over, and we have Matma 140, and we're not sure if that's Matthew Morrissey. So if it is, please put your hand up and we will move you over. Um, Not sure about that. Okay, sorry for interrupting. Go on.
No problem. Thank you for being on top of that, Mary. So I'm going to start off with Sarah Hulling. If you would be willing to introduce yourself and give us just a little bit of your background and welcome.
Well, thank you guys for having me. And I love the move where you increased your number so that you could include more than just one of us. So welcome to the other new member. I am in Forks, Washington, and I am an elected hospital commissioner out here. And I hold a doctorate that's focused on claims-based utilization as a measure of access. So I have a master's in rural healthcare as well. And I like to say that I'm from the trenches. I'm an imaging professional, and I sometimes describe myself as having X-ray vision and ultrasonic super tech powers, where I can tell you how it's really working in the real world here. So I'm excited to be a part of this team and to bring some of my other policy work into the mix and have robust discussions with everyone. Thank you.
Thank you so much. And I just want to make sure Hulling is that the correct pronunciation?
It's Hewling.
Huling. Okay. I thought the first meeting we'll get it right this time and then we won't mess it up anymore. So apologies, Huling. And thank you so much. So
Well, you're
excited
not
to have you.
you're not special in saying it different ways. So thank you.
Yes. Next up, Hiroshi. Would you be willing to give us a quick introduction?
Sure. So yeah, thank you, and really looking forward to working with this group. Um, so Hiroshi Nakano, I've been in healthcare management for most of my career. Most recently at Valley Medical Center, where I was focused on value-based care. I was responsible for value-based care at Valley. And then, it's Valley's association with UW Medicine, working in conjunction with them. So, very familiar with the value-based work associated with the PEM-SEM population and the Boeing Company and 26 other contracts. Um, my career, I've been in different areas of healthcare. I've worked for insurance companies. I worked for provider groups. Um, I've done quite a bit of volunteer work in healthcare, mainly in the governance area. So, like currently, I'm on the board of the exchange, where I know Pam very well. Um, I also sit on the board of International Community Health Services, which is a community health center mainly focused on the Asian Pacific Islander community. And I also sit on the board of Healthier Here. Currently I'm the treasurer of Healthier Here, accountable community health uh, under the Medicaid transformation. So I've had a pretty varied background, which is pretty interesting. Most of my focus and a lot of the interest of being on the financial technical advisory committee has been on the financial side of healthcare, both operationally and from a policy perspective. So I'll stop there and just say thank you again for having me here.
Thank you so much, Hiroshi, and thank you both for joining us and taking the time. As folks can see, two very well qualified individuals. So really excited. And now I'll just continue on with our regular roll call. And if folks want to introduce themselves as well for our new members, welcome to do that. Or you can just say here, whatever your preference is. Christine Eibner.
Hi, I'm here. I'm Christine Eibner. I'm a senior economist at the Rand Corporation.
Thank you so much, Christine. Eddie Rouser.
Hello, President. I'm a senior data scientist at the Healthcare Research Center at OFM, Office of Financial Management, and I lead the Medicaid forecast group, which we're
Thank
currently
you,
in the
Eddie.
midst of the February forecast.
Yep, sorry to interrupt. Okay, thank you, Eddie. Appreciate that. Esther Lucero. Esther Lucero. Okay, noting Esther as absent. Kai Young.
Hey, welcome to your new members. I'm Kai. I am a senior healthcare research scientist at Amazon Health Services. I am trained both as a clinical pharmacist and a PhD in pharmaceutical economics.
Thank you so much, Kai. Matthew Morrissey.
Matthew Morrissey, and I'm representing the Department of Revenue on this panel.
Thank you, Matthew. Pam McEwen.
Hi, welcome to our new members. We're excited to have you. I'm Pam McEwen. I know Hiroshi from my time as CEO at the Health Benefit Exchange, and prior to that, I was at Group Health Cooperative for 16 years in an executive role. Currently, I'm retired. I'm doing kind of a part-time gig with the Purchasers Business Group on healthcare costs and trying to get a handle on affordability with healthcare.
Thank you so much, Pam. And thank you again for taking on the role again of the liaison. So thank you.
Yeah, thanks, Ross. Happy to do it.
Robert Murray.
Yes, hi. Welcome to the new members. I'm Bob Murray. I obviously here, and my background is I used to be the executive director of the Maryland All-Payer Hospital Rate Setting System. So my background and expertise is in cost containment, price and spending controls, and regulatory models to do that. So anyway, welcome, and enjoy, or look forward to interacting with you.
Thank you, Bob. And Roger Gantz.
Likewise, welcome to our new members. Like Pam, I am a part-time retiree. In my former life, I was the Medicaid policy director. So I guess part of my expertise is all things Medicaid with delivery systems, reimbursement, etc. And I spent a bit of time working with the American Indian Health Commission. So I bring some background in the tribal delivery systems. And I'm currently a volunteer with something called Healthcare for All Washington. It's an advocacy group, eventually trying to move our state towards a unified single payer system. And again, welcome to our new members. Very excited.
Thank you, Roger. Thank you, everyone. We have a quorum today, so we will be able to take a vote. And the next item is a vote to consider the November meeting minutes. In Tokina, I believe if you advance one more slide. Yes. That you'll see on your screen and in your meeting packet, there are the November meeting minutes. Again, for our new members, this is a very high level summary of what occurred, specifically what business occurred at the last FTAC meeting. And so we just asked our members to review and make sure it's accurate and let us know of any errors or omissions, and we can update that. And provided it looks okay, we typically move on to a vote to seek approval of those. So if there's, and unless there's any comments on these, I will just proceed to the vote. Not seeing any hands. Is there any discussion of the minutes or proposed changes? Is there a motion to approve the minutes?
So moved.
Thank you. Is there a second?
Second?
Okay, Roger seconds. All in favor, say aye.
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 Any?
Aye.
Aye.
Should we abstain, the newbies, or
Aye.
I believe that would be appropriate. Yes, thank you.
I'll abstain?
Also abstain.
Thank you both. Any opposed? The motion is approved and the November meeting minutes have been approved and are now part of the record. Next up is public comment, and I will hand it over to Mary for that portion.
Thank you, Ross. Public comment portion of our meeting. Usually Sarah and Hiroshi, when we have written public comment ahead of time, we include that in the packet. This time around, we did not receive any written public comment in the couple months preceding this meeting, so we can just move on to the oral comment during the meeting. Our usual way of going about this is people who sign up ahead of time go first in the order in which they signed up, and then we open it up to the floor and people put up their hands to make a comment. So we'll hear from individuals first who signed up ahead of time, and it will be 90 seconds of comments. And one person signed up ahead of time, and that was Maureen Brink-Lund. So Maureen, please let us know your name and your affiliation, and we're happy to hear your comment.
Thank you very much, Mary. And thank you for all those introductions. It was really lovely to hear about everyone on the FTAC. My name is Maureen Brinkland, and today I'm representing a group of healthcare advocates focused on the UHCC and the FTAC. We're a subcommittee of healthcare as a human right, and we nickname ourselves HUCS. And my comment today deals with the OIC proviso funding. HUCS unanimously and strongly recommends that the highest priority for the OIC funds should be to hire the most qualified consultant who can study options for financing the universal healthcare system. The consultants can use existing actuarial analyses, such as those provided by the Universal Healthcare Workgroup and by Washington State Health Trust, among many others, to answer the following questions. What are the funding sources and the funding levels that could generate enough money to pay for the healthcare provided by Washington residents? What is the estimated range about how much Washington residents will pay per year individually, not in aggregate, to fund the new universal healthcare system? How does the estimated cost to individuals compare with what individuals are currently paying? Keeping in mind that we already pay for healthcare, but we are paying in the least economical, least rational, and least efficient way possible. The third discussion point under tab 7 asks, does the focus and progress of this work impact or inform the timeline of relevant universal design elements? The answer has to be absolutely, given that without answers to the financing question, the universal healthcare plan will be stuck in permanent planning limbo. The fourth discussion point asks, how do we determine if a topic is too far out of scope for designing a universal system? Can financing be out of scope? It is essential. Thank you very much, and best of luck for this year. Thanks.
Thank you for your comments. Now we will open it up to folks. If you would like to make a comment, please put up your hand. I see one hand up. It's identified as Whole Washington, so I'm not sure who the individual is. So please let us know your name, and we're happy to hear your comment. And it may take a second, once you accept the panelist link, it may take a second before we hear you.
Yes, thank you, HUCS Committee. My name is Thomas Kennedy, and I am with Whole Washington. As FTAC moves into the new year, I know there's going to be a focus on finding the $20 to $30 billion required to pay for universal health care in Washington State. This is very important, and we look forward to the Commission's work. It is important that FTAC and the Commission as a whole continue to make this important work come to completion as quickly as possible, because this, as Maureen said, is very important to the overall plan. There are ideas for funding out there. I recommend checking out the work of Balance Our Tax Code, which is a coalition that finds progressive revenue, along with the Washington Health Trust, Whole Washington's Universal Health Care Bill. 20 to $30 billion is a lot of money, but it's important to realize that so much money is going to be saved by both employers and governments by implementing universal health care. Lastly, I encourage this group to be bold with the collection of funds and to not push costs onto patients through copays or premiums or any other sort of vehicle. We will not have good universal health care while many among us still defer treatment due to costs. Thank you for the work that you do, and thank you for giving me this chance to speak. Thank you. Bye.
Thank you for your comment. I am not seeing any other raised hands unless I missed somebody. We'll give it another second. All right, I think that is, well, I don't see any other hands, but I do want to say thank you to everyone who sends written comments, everyone who makes the comments during the meeting. It's all very important to our work, and we really appreciate your input and your time and your attention. Takina, if we can go to tab 3. The next agenda item is mine. So Ross, I'm not turning it back over to you. I'm just going to jump into tab 3 and give the work plan update. Oh, there we go. Okay, so the update is pretty straightforward today. We're going to give an update of the work plan status and also a revised work plan that we presented to the commission in December, and it was very popular with commission members. It's a slightly different work plan from what we showed at our last FTAC meeting, so we want to get everybody up to date on that. So if we can go to the next slide. Here's where we are. We are on today's agenda, we are focusing on provider participation and reimbursement. And the text to the right gives you an idea. We're talking about the guiding principles. We've gotten some feedback on that. Thank you very much. Also, a draft outline for the proposal that the work group will reconvene after this meeting, getting the feedback from FTAC and really start putting in the details of that provider reimbursement proposal. So eligibility, benefits, and services are green. Provider reimbursement is orange. And that's where it stands right now. So if we can look at our next slide, it's the work plan again, but with a whole lot more words added to the slide. And I want to call your attention to what's different about it from the last time we showed this to you. The last 3 elements, when we last talked, we talked about maybe having an operations committee somewhere down the road. We talked about the commission doing transitional solutions in 2026, and maybe an operations committee taking on these last 3. Since that time, we've had some staff changes, some staff shuffling. We've gotten feedback from the commission, feedback from FTAC members, and we've changed that plan. And now what it looks like we are going to do is those last 3 will be going to the commission soon, starting at their February meeting. So those last 3 elements, enrollment, infrastructure, and governance, the commission will take the lead role in developing those proposals. That means we won't have to stand up an operations committee. It will complete the core elements sooner. And right above that, if you see that, financing still goes to FTAC. So provider participation and reimbursement still live with FTAC. The bottom 3 will live with the Universal Commission. And also under financing, I realized earlier today, the slide is misleading. Apologies for that. It says FTAC takes lead role on financing in early 2026. The lead role part is accurate. I think the early 2026 part was perhaps a little too hopeful. When I put together this slide earlier, I think it's more likely to be later in the year, given that provider reimbursement is still on everybody's workload. So the next slide. Just open it up to questions about that. And new members, if I did that too quickly, let me know. That is the picture that we try to touch in on every commission meeting and every FTAC meeting just to see where we are on the pieces of the work. Roger.
Yes, Mary. A clarification. When we had previously talked before the FTAC group, there was some notion about completing a portion of those identified items and that FTAC would, if you will, terminate possibly other groups coming on. And based on my conversation with you and Ross, it's my understanding that that is not the case, that FTAC will continue its work in these areas that you've been identified, plus as time affords to provide other supportive work to the commission, for example, in governance, infrastructure, et cetera. Is that correct?
That is correct. And in fact, that's part of the commission report out, but we can touch on it now. We took some questions to the commission, some questions that had come from FTAC members about, what is likely to be the final deliverable? What is the future of FTAC? Are we really going to sunset after financing? And the commission gave us the feedback that they would very much like FTAC to continue its work. Now, the meeting cadence may change. That's entirely possible, depending on, when things wrap up, what the pace of the other design elements, but they certainly want FTAC to remain intact, available, advisory role, help out. I don't know if you have any more synonyms for that, Roger, you can throw them in. But that's definitely the feedback we got. The other question we posed that came from FTAC was, what's the final deliverable look like? Is it a report? What's the format? And they were very intrigued by the question. They did not come up with a definitive answer, but there was certainly interest in figuring out what that would look like. Roger.
All right, maybe this would be later in the discussion. I had the opportunity to listen to the commission's meeting and the presentation that Ross made to them on this notion of deliverables. And I think I would kind of want to propose to restate it a little differently in that not only was what are the deliverables that the commission is looking for from FTAC, but maybe more critically, what is the final deliverable, if you will, that the commission sees that it would be eventually presenting to the legislature? And the reason for that is I think that the notion of that final deliverable is going to set a context and structure for the work that not only the commission's going to do, but the ability of our work to continue to support the commission. So it's, Ross, does that make sense what I'm trying to articulate?
Oh, absolutely, Roger. And that's been a question that I know has been on the commission's mind for some time is what a final product might look like. So apologies if that wasn't straightforward, but I think as we continue that conversation with the commission about what a final product for FTAC looks like, I think that will go to your point, Roger, hand in hand with identifying what that final product for the commission will look like as well. And also just wanted to echo when we brought this topic, the commission, they were incredibly clear that they relied on and appreciated this body's recommendations and work and really depended on a lot of the product that came out of here. So it was a resilient, please keep FTAC. So I, just wanted to echo that and say thank you. And it's clearly incredibly valuable to the commission and certainly to staff. So thank you all. And did that answer your question, Roger?
All right, thanks, Ross. And yes, thank you to all. Oh, Matthew. I'm going to say thank you anyway to all the FTAC members, which is what I was starting to say. Did you have a question, Matthew?
Yeah, is one of the potential products or outcome of the commission actual legislative language, or is it going to be principles or a plan but not legislative language?
Feel free to offer other thoughts. I don't have enough information to say a complete yes or no, but just from looking at passports and commissions and how they've been structured, typically proposed statutory or legislative language isn't usually part of what a border commission might do, but I could see, if we did a report that wrapped up all of our straw proposals and previous conclusions, I think that that could pretty easily be translated into a bill, but we don't usually put it into like the bill format. That's usually something that comes from legislative staff in legislators, but certainly within the realm of possibility and something that could be considered if folks had strong feelings about that preference.
Thank you. I'm just curious.
Thank you.
Thank you.
Any more questions before I send it back to Ross? Okay, Ross, you get to do the commission update, which we actually just talked about a bunch of that. Thanks, Roger, for moving us along.
Yes, thank you, Mary. And Tokina, if you would proceed to the next slide. Thank you. So I'm going to just give a brief update from our last Universal Commission meeting, which happened on December 11th. It was a really fantastic meeting, and it started off with public comment. At least in my time here, I believe that's the highest volume of public commenters that we've received, and the vast majority of them were what I would refer to as kind of citizen comments, which are really helpful and beneficial to the commission and to staff to hear those. There was a variety of comments or, types of comments that came out of that, but many personal stories about the challenges of the rising costs of healthcare, the incredibly difficult choices that Washingtonians are having to make between choosing healthcare versus, other necessities of living. The other part that really stood out was the sense of urgency that folks had and that they were trying to convey to the commission about, prices are already high and they're continuing to rise. And we face several other challenges, on the federal front as well as our state budget. So really challenging the board and staff to move on this sense of urgency. So that resonated with many of us. Encourage folks, if you have the time, to go back and listen to that. In the meeting minutes that are included in this packet, there's a clickable timestamp that will take you right to the public comments in that recording, if you have the time and capacity. Next, as we had referred to in kind of the opening section, we took a vote about adding some new FTAC commission members. And as you can guess, we voted to bring in, the commission voted to bring Hiroshi and Sarah onto FTAC and to expand our membership to up to 10. Previously, it was 9. So really appreciated that flexibility that the commission had to expand as we had a number of great candidates and thought, the more knowledge and experience we can add to this body, the better. So thought that was a great outcome and welcome again, Hiroshi and Sarah. Really glad to have you here. Next, we went into a really good discussion of the healthcare cost growth benchmark, which is a product that the Cost Board works on annually. For folks that aren't as familiar with that, the Cost Board on an annual basis performs a data call where the carriers and large provider organizations submit data to the Cost Board, and they roll that up into an analysis of total healthcare expenditures throughout the state. And then we measure growth year over year. The Cost Board had established benchmarks that are serve as a target for the amount of growth that we would classify as probably affordable, and anything exceeding that would therefore be unaffordable. That current benchmark is set at 3.2%. The data call that we just performed was for 2023 was the data that we received, and the rate of growth was 6.2%. And again, our benchmark was 3.2%. So And that was across all markets and segments. So it wasn't just one particular area that was growing faster than others, whether it be commercial, Medicaid, Medicare. There is growth across the spectrum. And so we had a really helpful, discussion about that and trying to dig a little bit deeper and seeing what pieces of that effort, the cost growth benchmark, could be useful to the commission and thinking of ways that we might be able to share and harmonize that information together. So again, there's much more detailed information about that included in you can click through the meeting minutes or access the commission's December 11th meeting packet with that full presentation there. So, and happy to take any. Oh, I see. Sarah,
And
please.
also there's if you advance the slides a bit, there's more detailed slides about
Oh,
checking if we go to I assume Sarah, your question's about the benchmark. So maybe one more slide. There you go.
thank you, Takina. Apologies. I did not give you good direction to keep those moving. My apologies. Please go ahead, Sarah.
Yeah, I was able to review some of that. And my question was so it looks like there's a call out for the payers to submit data. Was that a special request, or is that something that's already coming through another entity just naturally, or is this an additional ask from the payers?
I'm not exactly sure what you're referring to. We do annually as part of our data call process. We're about to actually launch it for our 2026 data call here in the next month or so. And we collect data from all of our carriers as well as large provider organizations, which I believe is defined as covering more than 10,000 lives. And they submit data to us through a somewhat informal process that's directed by the cost board statute regarding a variety of data points that we then aggregate and kind of translate then into our total healthcare expenditures and a variety of other measures to try and track the health of Washington's healthcare market. I'm not sure I hope that answered your question.
It does. It always leads to another question, though, and I apologize.
Sure.
No. The all payer claims database, is that being utilized in this process? The Washington all payer claims database?
So it's in terms of the data call, that's what we consider kind of the first step in our annual review. So that is the information that was presented at the last meeting and was included in that packet. The kind of next step that we do on an annual basis is something we call the cost driver analysis. When we dig a layer deeper, part of what we do with the healthcare cost growth benchmark analysis that we presented in December is identify the key contributors to growth. And it's been basically the same year over year: retail pharmacy, non-claim spending, hospital outpatient, professional specialty tend to be the cost drivers. And then we do a cost driver analysis in which we utilize the APCD to dig more at the claim level than the aggregate level. And typically with those cost driver analyses, we pick a question or an issue based upon a trend or something else that we're seeing in the aggregated data to dig a little bit deeper and help us refine our policy recommendations.
Okay, I promise. Last one. So the call out, they're submitting it in this informal way. It's not going through the all payer claims database first. It's going to this entity and someone's heading that up, it sounds like.
Well, I don't want to get out over my skin because there are tons of technical details that I may miss. So I'm happy to be corrected. But the way I would describe it is those claims are still going into the all players claims database. We are doing a separate data call to collect the specific information related to developing the healthcare cost growth benchmark and the total healthcare expenditures. So I do not believe that allows them to not have claims included in the all payer claims database. So I believe they're both happening simultaneously.
Okay, thank you.
Yes. Roger, I think I saw a hand.
Yeah, very briefly. Uh, That the analysis is generated through the all claims database. So it's not separate data calls from the provider community. And as you know, Washington is, I think, one of at least a half a dozen states, if not more, that have all claims databases. I
Yes.
forgot the total number, but that is the origin is, as Ross was saying, of the data that's used in the analysis. The analysis itself, as Ross indicated, is performed by the Healthcare Cost Transparency Board and Healthcare Authority staff.
And I see Harrison, who is our data technical person, is going to offer some corrections, I assume. So thank you, Harrison. Please go ahead.
Hi all, Harrison Fontaine. I support the work of FTAC and the Commission, but also I'm involved with the data call, which is relevant to this conversation. So I think it's roughly what we've discussed so far is pretty accurate. I would offer a correction that there are really two streams of information that come to the cost board. One is that really rich source of claims level information that comes from the APCD. To complement that, and to gather things like non-claims data, right, these bundled payments that go out to providers, we, through a fairly formal process, starting actually this next month, request that data from providers. It's aggregate level data, so we're not going down to the claims level. And that is the information that is informing this performance against the benchmark and this sort of aggregate high level trends analysis that you're seeing and that Vishal, our chief data officer, presented on most recently to the commission. So two different complementary streams of information. The data call informs the performance against the benchmark, this high-level trends analysis, and the APCD feeds into a cost driver analysis, which allows us to sort of understand what is behind these high-level trends.
That was excellent. Thank you, Harrison. Okay, and I will just quickly move on to the FTAC direction slide. We covered this in the last section, but again, just want to reiterate the Universal Commission was adamant that we maintain FTAC, because of the fantastic work and guidance that comes from this body. So FTAC will continue as we had on the work plan and probably still some questions to be answered about what happens once we finish the work plan. We had talked about keeping FTAC, in place to help support questions as they come up, but we'll probably need to do some more thinking. So we'll probably be bringing questions to you in upcoming meetings about what that might look like. But we still have a fair amount of work ahead of us before we get there. And so now we're going to move on to FTAC's work on provider reimbursement. And we're going to start by looking at the guiding principles that are going to be guiding the straw proposal that we're working on. And I'm going to turn it over to Harrison to lead us through that.
Hi again, everyone. And Tapina, can you go to the next slide, please? And the next slide. Fantastic. All right, so to bring everyone up to speed, this is what we're going to be talking about in the next 20 or so minutes. I'll provide a quick background as to sort of where we are in this process of drafting and refining the guiding principles that will really inform the more specific recommendations for provider participation and reimbursement. We'll go through really the specifics of the draft and some written feedback that we've received so far. And then we will open it up, of course, for discussion, refinement, and hopefully a vote so that we can keep this moving along and get a draft in front of the Universal Healthcare Commission. All right, so the draft that you'll be looking at today has been informed by input, of course, from FTAC members in the last couple of meetings, as well as some public comment received in those meetings. And a work group comprised of FTAC members was formed to develop a set of guiding principles that really will serve as a standalone document that informs the specific recommendations for provider reimbursement for that design element and will sort of guide us as we put more specifics to these recommendations. So the work group, which was comprised of volunteers, was developed we've gone through, or they have gone through, a series of drafts and really sort of honed their thinking. A recent draft was circulated to FTAC members, I believe, in December for review and comment. We've received a few comments that we'll be walking through in the next couple of slides. And as we walk through these slides, it might be easier for some folks to follow through in Appendix A, which is where these draft guiding principles are all together. And if these principles are approved by FTAC members today, we will be able to stay on track with that work plan and that timeline that Mary presented earlier, and we'll go in front of the Commission for their consideration during the February 2026 Commission meeting. And Takina, can we go to the next slide, please? Fantastic. So I think we'll step through this in a few different chunks. As I mentioned, we received comments. We didn't receive comments on all of the proposed principles, so we'll step through them in a few different sections. The first principle we did receive comment on, and this one relates to reimbursement systems across providers and payers. I'll read sort of the specifics, which is what informs the higher level titles for each of these. So in the current draft, Principle 1 reads, the reimbursement system should use consistent reimbursement designs and rates for all enrollees in the universal financing system. Alternatively, there's been a proposed revision that really swaps out this word consistent for the same to read that the reimbursement system should use the same reimbursement designs and rates for all enrollees in the universal financing system. And on the slide here, you can see the rationale behind each of these different versions of the Principle 1. Essentially, and we can ask for some clarification from those that offered these principles and the specific language in a second. But using the word consistent, essentially the framing there is that these principles are intended to give the governing body ultimately a strong direction in how to design the payment system, but won't be too prescriptive and won't tie their hands and will allow for essentially some wiggle room and some flexibility when potentially there is future legal challenges. Alternatively, the idea with really using the word the same is to highlight and to solidify this thought that the same reimbursements and associated payments will be used across the system to reimburse providers and services for services to all enrollees, regardless of various factors. So I'll pause there. Again, we're really trying to figure out this difference between consistent versus the same. And I see we have a few hands. I'll first go actually to Matthew, and then I believe we got these proposed revisions from Bob and Roger, and we'll allow clarifications there. So Matthew, can you please go ahead?
Excuse me. Just to note that on the next couple slides later is going to be a very similar dynamic, what I propose as far as making everything the same versus at least putting some guardrails up, but allowing for exceptions. And so I don't know if this is the same, kind of the same issue in a way that's in the future slides. I just wanted to bring that up. I don't want to hijack the discussion over this one in particular, but I think this overall question that we're facing is whether to lock in, everything is the same and not allow some exceptions where the marketplace doesn't meet the need, and you need to have some higher payments or higher reimbursements to draw providers or facilities to open in certain areas. And so I think that it relates to this, and that's all I wanted to say for now.
Yeah, excellent point. Definitely a different sort of lens on the same issue. So something that we'll be working through here. And Bob, please go ahead.
Sure. Yeah, I had advocated for something a little broader than what Roger was advocating. Having run a large rate regulatory system, the all-payer system in Maryland, I was very much attuned to the usefulness of some flexibility in the language, as long as so the regulators can interpret the legislation and the statute in certain ways and act accordingly, as long as whatever the issue you're dealing with is consistent with your overall goals and principles and that you are constrained by as a regulatory agency relative to the statute. Um, and so I was worried that the use of the word same could be used by in legal challenges. And just operationally, you don't want to set the same rate for every service and every provider. I mean, maybe that is not the intent, but by using the word the same, it opens up the possibility for the individuals or entities to argue, oh, look, you can't make this variation because your principle, or even if it's in statute, doesn't allow you to do anything different. And I do believe, although staff didn't mention this, there was an email that was sent, I think, from an AG in the state, sort of raising the same point. They said, well, what about if you make it the same, does that handcuff an agency where they couldn't make exceptions and maybe provide higher rates to a struggling rural facility or a facility in the inner city? And I would say, yeah, it makes you vulnerable to a legal challenge if you make those sorts of variations. And believe me, the advocates, the entities that are being regulated, will throw everything at you. And so that's why it's good not to be so prescriptive. Now, the reverse is also dangerous to make things so broad, it's difficult to interpret. But that's why you kind of relate to other elements of your principles or goals or objectives when you refer to these sorts of things. So what I would suggest is continuing to use consistent, but then maybe saying as long as these rates are and variations are consistent with the overall principles of the universal healthcare initiative, something along those lines. But the same, I would just blanch. I wouldn't take the job as an executive director if you had this language in where it forced me to make the same, prices and rates and the same methodologies for all circumstances. That's just in my mind nuts
Thank you, Bob.
from the legal standpoint. So anyway, that's just based on 17 years of experience running a regulatory agency.
Of course. And apologies, I'm not sure which order the hands have appeared. I appreciate everyone raising your hands. I'll just take them in the order that I see them. Let's go to Pam next.
Yeah, thank you. I have a little bit of a different angle on what Bob said, although I lean towards the use of the term consistent over the same. I think, I certainly appreciate the same. I worked in a large health system where we had the ability to do things the same way because it was a closed system. But one of the things I want to be mindful of is that the Universal Healthcare Commission, who we support and who are really in the lead on this, haven't made certain decisions or given certain guidance that would kind of add clarity to these kinds of decisions. And I think that we have served them the best when we've given them as much flexibility as possible. And I think using terminology that kind of presupposes that there are more decisions to be made, different ways to look at this, would give the commission that kind of flexibility, which I think they really need. I think that's how we have the dialogue between our group and their group when we have that flexibility.
Appreciate that, Pam. And certainly, yes, this is really the beginning of a conversation with the Universal Healthcare Commission, and these comments will be filtered up to them in the reports out. So we'll be capturing this and relaying it on to the Healthcare Commission. Hiroshi, I see your hand.
Yeah, thank you, Ross. So my question is really maybe as a newbie, has the discussion around this and the goal of the principles to be like an endpoint guide? So this is where we want to get to. I know this discussion around the word consistent versus the same is a little bit more of a process type question, issue. But my concern is that the need for flexibility and the evolution of reimbursement, having been on the provider side, not every provider is ready for certain types of reimbursements schemes. And so could threaten, frankly, the existence of certain, having done global capitation back in the 1990s in the state of Washington, there are provider groups that no longer exist because they were trying to take something on they couldn't handle. So sometimes being too prescriptive out of the chute won't get you what you really want, which is a sustainable system. And which brings up another point too. I didn't actually see that word sustainability in any of the principles, and we might want to consider that.
Yeah, and to your point, yeah, these guiding principles are, primarily to inform and guide the work on the actual recommendation that we'll be actually sort of talking through the details of next. And so, yeah, appreciate that comment on flexibility, and really the rubber meets the road to some degree here, but also in that recommendation that will follow. So let's go to Sarah and then Roger. And after that, I think we should move on to the next 9 design or guiding principles as we're starting to run a little short on time. Go ahead, Sarah.
I am attempting to paste things in the chat, if that's helpful. And I think it speaks for itself. So I don't want to take up time if I'm able to just kind of paste it there. And if anybody has questions for what I'm trying to articulate, I'm happy to answer them. I think some other people, the same is hard when you're in rural. So it's, I think there's a concept around adequacy versus capacity. And I'll leave it at that so we can, I don't want to hold up business. We could spend a lot of time and I'm a newbie, so I'll try my best to follow the pace of others. Thank you.
Yeah, just Sarah, maybe you could elaborate on, which I had a hard time following your text, and it was kind of all over the place, in terms of format. So if you could elaborate or just reiterate, and then just also which of the two approaches, consistent or the same, would you support?
Okay, yeah, sorry. I like to make a lot of points and try to answer it in my own head. So I think I kind of did like an overall comment. This principle clearly addresses payer equity, which is important. It may be helpful to clarify whether it is intended to address adequacy or access as well, since claims-based utilization suggests that equal coverage does not always translate into service availability. So, do I have a solution? No, that's
Well, to answer your first question, I think that this relates to reimbursement, primarily, the principle. So it would be payment mostly. I mean, I also, just looking at your thing, I don't mean to be argumentative, but I would also sort of say that payment adequacy is not sort of embodied in this currently. But I would also take exception with, you were sort of indicating that payment was too low. I personally don't think even public payment is too low. I think the problem is that we've let hospitals in particular and other providers increase their revenues and their spending, and as a result, they've spent it on many things that are valuable and not valuable, and increase their cost base. So as a result, payment levels appear inadequate, when in fact, for Medicare and Medicaid, if a hospital was efficient, they could survive under those payments. But anyway, adequacy is maybe sort of a different topic, I guess, is my point here. And I was just reacting more to the payments, not handcuffing the agency so that they are required to do the same payment for every circumstance. And, per the examples I've given, and also the AG said, what happens if they're rural facilities, you want to give them a different rate, which may be justified. You want the agency to have the flexibility to do that.
And I'm in support of that. I'm in support of that flexibility. Absolutely. Yeah. I would like world peace. So I am just saying, if we have to make exceptions in the rural area, then the policy is it's already fractured. But I don't want perfect to be the enemy of good enough. So
I'd like to keep us a little bit on track here.
Thank you.
We have a lot of work to do, and certainly a rich conversation that we can have offline. Let's go to Roger, and then we do need to move on to the next principle.
Yeah, this whole area has been one that I've been struggling with. And let me see if I can say this succinctly. That wording in the second option may not be correct. And it's in no way intended to say, for every location, it's the same reimbursement system. Or we're going to have variation, different types of delivery systems. And if this sentence doesn't capture it, then I'm arguing we need to rewrite it. But it's a basic principle. And the basic principle is, unlike the system we have today, where if you're in Medicaid, you have one set of payment structures. If you're in Medicare, you're another. If you're in a commercial, you have another. For example, if you're UNP, you have another set of reimbursement payment structures. It's to say in this universal system, we're not distinguishing by your payer source. That if I come into this universal system and I'm financed through some federal dollars that are Medicaid, which we would use in this system, we're not going to pay at Medicaid rates for Roger. These rates are the same for all individuals. That's the theme I think needs to be stated. And it's a fundamental. If you look at any universal system, do not divide people up into categories for eligibility purposes. That's what, and I'm not saying the same captures. It has nothing to do with having the same system in a rural area or urban. It's nothing to do with that. It's just.
Roger, if I could just respond. The problem is you have your own definition of the same in
Well,
your
then
head.
I'm asking. What I'm pushing back on, Bob, is a clarification that everybody who is in this system is treated in like fashion, and they do not discriminate based on Medicare, Medicaid, the systems we have in place today. Now, if this notion of same,
You mean in terms of price?
that,
Excuse me. You have to be clear. In terms of price?
yeah.
Yeah, okay. Well, day one, you start in a universal system, you're going to start out with these differences. So you violated the same principle right off the bat. Now,
I respectfully disagree with that. We don't know how we're going to get there.
Robin, excuse me, sorry. Yeah. Thank you,
So,
Harrison. Yeah.
Really, rich conversation, and I appreciate the importance in getting these small details right. This is something that I think that there is some daylight between members of the group, something that we can, I think, as Pam alluded to, raise up and highlight for the commission. And as FTAC advises the commission on these things, we can highlight that difference. Perhaps consistency across payers is something that we'd want to highlight, or at least have them consider.
But again, I think there's a difference between doing this on day one, which is not politically or economically feasible, and striving for
these are guiding principles to try to get us where we need to be as an end state. I understand that we're going to go through a transitional process, but what is the end state?
Yeah, then reflect it that way.
Bob and Roger, greatly appreciate the passion here. Apologies, I hate interrupting you. Just acknowledging that we do have 8 more principles to go through here. So part of this process was to see if we could come to some consensus on these. I'm not sure if we're going to get to consensus on this one. So just flagging, we're trying to take notes with this group, and then we're going to bring these conversations, the points Roger and Bob and Pat, everyone has made, and bring that to the commission and see if they have a preference that we can get them to. So I love the passion and the strong strategic thinking on this. So, and hate to cut off folks, but do want to make sure we get to the next ones. Sorry to interrupt, Harrison.
No, thank you, Ross. All right, so Takina, thank you. So we're going to walk through the next 3 sort of in tandem. So Principle 2 relates to affordability of healthcare. It simply states that the reimbursement system should improve and sustain affordability by promoting cost containment and increasing efficiency. We didn't receive any comments on that one thus far. Principle 3 relates to access to care. It states that the reimbursement system should promote the availability of needed and appropriate care for all enrollees with a particular focus on people in rural and medically underserved areas. And as Matthew highlighted earlier, sort of the same flavor of the conversation that we were just having on Principle 1, Principle 3 and 4 may be in slight conflict in that Principle 3 promotes care for all enrollees with a particular focus on people in rural or medically underserved area, but Principle 4, and Takina, can we go to the next slide here? Principle 4 suggests that the reimbursement system should promote equity, including paying providers uniform and consistent rates for the same services and be site neutral. A proposed alternative to that would be the same preface, but with the exceptions for higher rates or bonus payments to providers operating in rural or medically underserved areas. And again, it's trying to reconcile this conflict between rural, between wanting to promote providers and draw providers to rural and medically underserved areas with this financing system and reconciling that difference. Again, let's open it up for comment. Bob, I see your hand, and let's, yeah.
Yeah, again, I do disagree with the use of the word same again for the similar purposes. So I just think from a regulatory standpoint, it's useful to point the direction and strongly point that direction, but not use language that could handcuff the agency down the road. And again, the use of the word same does that. Plus, I mean, you could call out rural and underserved, but you may want to make the authority for the governing agency a little broader than that, where they can address other issues, because it may be that there are other areas and other types of providers that are disadvantaged in the future. So you don't want them only to be dealing with rural and underserved. So again, the broader, the better, and the more flexibility you can give an agency, the better. And specifying things and using words that can be interpreted in ways that reduce your flexibility, I think, are problematic. But that's my general point.
Yeah, I think perhaps, thank you, Bob. I think perhaps a rewrite on that one when we bring this up to the commission could be a more general statement about allowing for flexibility in certain areas, for example, or, something like that. And then, as you point out, Bob, we are not restricting ourselves to certain settings. So
Yeah,
I think
not
we can,
limited to blah, blah,
yeah,
blah.
I think we can certainly make that change and elevate that to the commission.
Right. Right. And it's calling out site neutral. I mean, that's just one of millions of issues. I don't know why you call it out in a principle. These things should be general and provide direction for the agency, not prescriptive about, okay,
Yeah.
just deal with these things.
Thank you.
Appreciate that. And Mary, love the suggestion to, provide examples, but not be confining ourselves unnecessarily. Are there any other comments on design principles 2 through 4? We did not receive any comments on the remaining design or guiding principles. Happy to entertain comments.
Could I ask sorry, Harrison, one clarifying question, Tokina, if you could go back to the last slide. Thank you. Is your concern regarding the use of same services, does that apply to both the draft principle and the proposed revision, as they both use same? You would prefer that language be changed, whether we go with the draft principle or the proposed revision, Bob?
Yeah, I would get rid of the word
Okay.
same again, and also pull out site neutral. I think you want to make these principles more general. And again, the rule of thumb is give the agency flexibility to address various inequities as they occur.
Excellent. Thank you. Just wanted that clarification.
All right. Let's go to Matthew.
I had a question about Principle 5. If Roger or Pam want to stay on this slide, I'm happy to wait.
I have a comment on site neutrality, so I think that's on 4. And it's just a quick one, which is that my experience with the term site neutrality is basic, like moving like a surgical service to a different operating room in a different building to be able to charge a higher rate. I may be wrong about that. I think site neutrality can mean a lot of things, but I guess I'm agreeing with Bob. It might be better to take it out because of how the terminology's been used in health policy over the last 5 to 10 years. It adds a lot of confusion and I think precipitated some concerns about access to care in rural areas by throwing that term around.
Appreciate that. Yeah. hearing consensus around taking out site neutral. Roger, go ahead.
Yeah, I would think I was part of the author of wanting to introduce the notion around rural and medically underserved areas. Um, I'm very quite comfortable with the notion of giving that as examples of emphasis. And the reason I'm saying that is these two issues in our healthcare system today continue to come up as critical issues. Rural health, time and again. We've seen strategies, both Medicare and Medicaid, to try to speak to those issues and in underserved areas. I'm not saying those should be the sole ones, but I think because of the struggles of those areas, to call those out as examples would be warranted.
Right.
And the issue around bonus payments and how you get there, here again, this is what I would agree with Bob. There are various strategies that could be employed, but it's an acknowledgement that when we're looking at reimbursement, one of the key issues is, do we have the access we need, right? And we tinker with all sorts of strategies. And these are two areas that are very critical in our state and will continue to be so. So as examples, I would encourage us to maintain that language, not the
Thank you.
bonus payment stuff, but the issue around rural and medically underserved.
Great.
Yeah, and if I could just very quickly, I agree. If you want to keep some reference to these underserved areas in, that's fine, but I wouldn't put in, bonus payments or,
Yeah, I agree.
again, that's prescribing things that it should be up to the agency to figure out how to deal with this inequity.
Great. All right. Appreciate all the comments on that. And yes, we will revise accordingly. Let's move on to Principle 5. And Matthew, go ahead.
I just wanted to get clarification on Principle 5. Does that mean paying primary, preventative, and outpatient behavioral health services higher rates than currently, but maintaining the rates for specialists? Is that what that's getting at?
That is a fantastic question. I believe that is the intent.
Yeah, I mean, it's I think that is potentially what it would be. I mean, I'm sorry, I'm thinking about the second half about the specialists, not the first half about the primary and preventive and behavioral health care. There have been efforts, particularly in things like the reference-based pricing bill. It's not only reference-based pricing, but it is rebalancing to try to increase the spend on things like primary care, preventative services, behavioral health. Um, so it is an effort to rebalance it away. I guess away is the right word from the heavy emphasis on specialty care.
Thank you.
Just a quick comment, if I should. I think fundamentally the specialists are overpaid, and there should be that rebalancing. But again, I don't know that you need to call that out in this principle. You should leave it up to the agency to rebalance payments. But calling out the need to improve payments for primary care, behavioral health, I think is okay as an example. You can keep it in as an example.
Great. Thank you, Bob. All right, so seeing as we're a bit over time, Takina, can we flip a few slides forward? There we go. I will pose it to the group. Hearing some disagreement still on some of the guiding principles, I do want to frame up that these are the guiding principles that really are informing the drafting of the recommendation itself, and it's very possible that we can offer these principles up to the Universal Healthcare Commission with some clarifications, and it doesn't need to be exactly a consensus document as we offer it up to them. But Mary, I see you're off mute.
Yeah, thank you. I agree that, I'm the person who put in the potential vote slide, but I think that's not where we're headed. But I do think we got some really good feedback that we can put to use. I think we need to revisit these, give everything a little bit more leeway, where we were more specific, make those examples. And I think we can elevate this. I'll see if the group agrees with me. I think we can elevate this to the commission and at the same time talk about the revisions and talk about some of the areas of disagreement and concerns and present this to the commission. I don't know if, okay, I'll just ask, does that sound like the right way to go? Roger.
Yes, I agree. I want to say one more time, and I'm not trying to be argumentative, and we wrestle with this notion, but I'm going to go back one more time. This fundamental aspect that I'm searching for words, But the notion I'm trying to get at is we do not want a fragmented reimbursement system that pays for one group of folks, poor people as an example, differently than they do people that are in Medicare or in commercial. It is the same system.
Mhm.
And that's not when we're the same, it's not you have the same type of reimbursement. I mean, that's not the notion at all. So I'm also, I know I'm not being very clear, but I would like for that to try to be captured and shared back
Mhm.
with that group.
Yep.
Thank you.
Hey,
Okay. Thanks, Roger.
Mhm.
and I was just gonna note as well, these are iterative in the sense that we certainly have the opportunity to come back and make corrections, update, because we haven't got to the provider reimbursement straw proposal to completion yet. And I imagine that could, maybe some information in there does cause us to rethink some of these guiding principles. So just want to reiterate that this is not a final version of this. We can always come back to it. And if we find out certain pieces don't work, we can certainly update this. So just want to give folks that reassurance that this will likely not be the last time we see this.
Fantastic. Thank you, Ross, and thank you, everyone, for the really rich conversation and passion on this. Really setting the stage well for the next discussion topic, which will be the design principle itself and the recommendations there, beginning to look at a draft proposal outline, putting some meat to the
Yep.
bones.
All right, and that one's mine. So thank you, Harrison. Thank you, everybody. Just a quick reminder of how we wound up with guiding principles and with the draft proposal outline. A few meetings ago, we were having this conversation, and the topics sort of divided themselves into two groups naturally, and then one thread of the conversation turned into the guiding principles, the other thread turned into the draft proposal outline. So we just wrapped up guiding principles. Now we're working out to draft proposal outline. If I could have the next slide, Takina. And the next slide. Okay, so this is what I was just talking about, developing the set of guiding principles. What we decided was maybe begin with hospital payments, then move on to providers, and a set of recommendations could be implemented. Think of things that can be implemented on a smaller scale and then broadened. I'm just going to pause for a second because internally and in some of these meetings, we call this a straw proposal. We've heard from the commission that everybody seems to hate the name. So if I say straw proposal, it's a slip of the tongue. Now we're trying to call it a draft outline or a proposal. If anyone has a brilliant name for the proposal, let us know. But we are hearing feedback that we shouldn't be calling them straw proposals. Really, what they are is the initial proposal, the initial recommendation from the commission to say this is a piece of the universal system. This is how we think it should be put together. And we're well aware that once we get them all done, all the elements done, they will need to be reconciled and make sure everything fits together. So right now, this is the proposal formerly known as a straw proposal, looking at provider reimbursement rates. So the next slide. We talked about at our last meeting what's in scope. And I just want to, this is the same slide. I just want to review it with everybody, repeat it. The guiding principles discussion we just had, hospital payment approach, expand reference-based pricing, gradual transition to hospital global budgets, other enforcement mechanisms. And we talked less at the last meeting about physicians and other providers for their framework. We talked more about hospital, hoping to get more input today on physicians and other providers. Looking at the incentives for providers to participate in this system. And then also, we always have our eyes on other work going on at the agency and around the state. We talked a bit earlier today about the Healthcare Cost Transparency Board. We have the actuarial work Milliman did. We have the SB 5083 is the reference-based pricing for PEB-SEB. We have analysis and studies that went into that work as well. So the next slide. Last time around, we agreed on what's out of scope for now, which is getting more into the details, the weeds of rate setting methodology, timelines, not there yet, administrative or technical systems, things like that. We agreed, and I'm just checking again, that's out of scope for this draft proposal outline. So the next slide. Here's how we see this work moving forward. I hope this timeline is clear to folks. This is a new format. We're all the way at the left in January. Today, we want the input and the feedback. It says draft proposal, really, it's a draft outline. In the month of February, the work group is going to get back to work, take today's input, add some text, put some meat on the bones, as Harrison just said, start kicking around a draftier draft, something we can actually respond to in text. That'll go back and forth with the work group. That also, our hope is that we will circulate it between meetings to FTAC members, get your feedback, similar to what we did with the guiding principles. In March, it comes back to this body to come all together and look at it. April will be the first time the commission sees it. We do not anticipate approval at that point. It would be great if we had it, but it's much more likely that the commission will say, okay, here's our feedback, here's what we think, here's what might have to change. In May, FTAC looks at again, and then June is when the commission could approve it. And if you look at the bottom box there, it says there's ongoing incorporation and feedback and preparation of revised drafts that comes from the FTAC work group, FTAC staff, commission. Commission staff and FTAC staff are all the same people. So that's how we envision that happening. So we're all the way to the left here. Still looking for some input on what we think the draft proposal should contain. So the next slide. So as we're looking at this, again, this is a draft outline. There's things just to keep in mind. Do we have the right topics? Are these all the intended topics? Should we add something? Should we remove something? Should we include a recommended time frame for implementation? I think we called that out of scope on a previous slide, but maybe we should include that as well. If we're talking about things that are essentially transitional solutions, looking at things that are in place and potentially broadening them, should we add a timeline to that? And then, are there topics we want to explore for further research? And these are some topics that came up in conversation. I don't know if it was September or November meeting, but I know there was, conversation about, well, if we change around this whole reimbursement structure, do we run the risk that providers are going to leave Washington? And under what conditions might they leave? How likely are they to leave? I'm not sure that's really in scope for the proposal, but that might be something to look at. If we have other ways to look into this or things to consider. And what about a potential care shifting by providers to either less regulated settings or non-regulated settings? Under what conditions might that happen and how much might that happen? So this is kind of what we want to keep in mind. Like basically, are we hitting it for what we want to include? So now I think the next slide actually gets us to the content of the draft outline. We're going to start with the hospital payment approach, looking at the transitional solutions I mentioned, which is start with reference-based pricing, then expand it to other markets. Right now it's PEBSEB hospital, maybe to local governments or commercial markets, maybe set out-of-network price caps. And that could lead us to universal design recommendations, global budgets, who has the authority for enforcement and data collection, or define services subject to budget and determine the rates, establish the base rate, adjust the rate to address care improvement volumes. So there's a lot here which would form the part of the recommendation looking at hospital payment. So I can pause and we can open up discussion here, or we can look at the next slide, which is also provider. I'm sorry, which moves to provider. Bob.
Yes. Well, so in terms of the actual sequencing, I just want to make a suggestion about just maybe a little more meat to some of the things that you would refer to, Mary, which I think is a generally a very good plan. But I would advocate starting with reference-based pricing for the state and public employee benefit program, which you refer to as PEB and SEB, similar to what Oregon did. And then expanding that to local governments to the extent that it's legal to do so, at least giving them the opportunity to opt in. So it'd be something like King County could opt into this, or some of the other local jurisdictions. So I think that's a very if the bill passes, which it did pass, I guess. But once it's implemented, opening it up, then I would recommend considering expanding it, just as you mentioned. The first area I would look at would be set reference-based prices for the commercial market for out-of-network hospital services. Again, that's an incremental step, and that's one of the principles I would advocate is do this incrementally because they're political considerations, but more importantly, you can't do a lot of these things immediately. They have to be transitioned and trying to make bold steps. You can make missteps and disrupt the delivery system. So reference-based pricing, public first, expanding it to the private sector in the out-of-network area, that will have an impact on what insurers can negotiate as prices with hospitals, bringing pressure on that, and then potentially expanding it to the broader commercial market, as Vermont has passed legislation to do. And then the third or fourth approach would be do all-payer hospital global budgets. I think if you take that last step, it would require a change in governance, that it would be more appropriate to have a separate agency, like a public commission style agency regulating, overseeing that broader system. And so I think that's a natural progression. We've sort of talked about that. That would be my recommendation. I do think it's also worthwhile to put some time frame on this because it's mostly important for the Universal Coverage Initiative to get a handle on costs. And the faster that the state can do that, the faster it can move towards more of a universal system. But until you deal with costs, a universal system is not feasible.
Thank you. Sorry, and I'm trying to read the chat as we're talking. Oh, you know what? Roger, is your comment on physician and provider, or is it on hospital?
I'm sorry, I'm going back to maybe a basic one to begin with. Just to reaffirm, when we were starting down, let's say, the path of eligibility and benefits, as an example, that was the providing principles or structure for the New World Order system. At the same time, at times we being FTAC were working on some transitional solutions, and likewise the commission was. And when I think about transitional solutions, again, it's sort of the pathway that Bob has been talking about. I just want to clarify that what the commission anticipates from us is especially as it relates to reimbursement, it is a combination of transitional solutions and or end state. And that's what they're anticipating that we will be providing them. So I'm posing that as a question.
I believe so. That they
Okay, because we kind of, I'm trying to go back, we kind of bifurcated things. For example, this last time through, we were going to work on the grand design, right? And then the commission was going to work on transition solutions. They decided not to do that, the transition solutions, if I understand correctly. So in this quote unquote world of transitional solutions, they're bringing those back under our, if you will, jurisdiction to provide information to them. I mean, that's what's implied here. I just want to.
Yeah, okay, I see your no, I see your question. I think the work plan that we are not implementing, the transitional solutions, how do I want to say this? The commission was identifying a set of transitional solutions to look at, and then they decided to take on the core design elements, but they did not decide, it's going to get really twisted around the way I'm phrasing this. They did not decide to eliminate transitional solutions from the core elements that FTAC is working on.
Okay.
Did that answer your question?
Well, it brings them back into what our scope should be. So yeah, that's very, very helpful.
Okay, thank you. Sorry.
Well, and one last thing, we get onto this. So a deliverable, I'll be real quiet about the one last thing, but we're talking about transitional solutions. I mean, part of that needs to be brought back to the commission and saying, well, we can provide all sorts of transitional solutions. It's their ownership of those and what they propose to do with them, I think is going to be extremely important. We could lay out a plan to move from, as Bob has done, he's been advocating for, let's start somewhere. Hospitals is the big one, obviously. So we're starting with the reference-based pricing to this, to this, to this, and eventually global budgeting. Well, it's not going to happen through us, right? And it isn't going to happen through the commission, those things, unless there's a vehicle that they're prepared to bring those forward to the legislature. So I'm wanting them to be thinking about that, because we can write up something and there it is. So what?
Okay.
Am I making sense?
No, it is making sense. And again, we can clarify with them,
Okay.
as we are taking the information and the draft to them, we can clarify that point about the transitional solutions.
Thank you.
Pam, did you want to add something? Whoops.
Yeah, I'm on. Yeah,
there you are. Okay.
I think so. I don't want to make it worse and more confusing. But I think about transitional solutions two ways. One is that the commission is charged with kind of coming up with improvements for the health system we have now. But as we look at payments, we remember that we talked about eligibility groups when we first began. Well, they're large groups that we are unlikely to be able to bring into a universal system. And that could include Medicare and it could include ERISA employees. So when I think about transitional in the context of what we're recommending here is you may move to a universal system in steps because you can't get your hands on the whole system initially, just kind of in terms of practicalities. So that's why kind of the way Bob is sort of stepping through how you might get a hold of hospital costs. It's not necessarily how you would ideally design a universal system, but the reality that we have, it may be a way that you could kind of step into it. So I don't know if that's what you mean when you say transitional in this context, but that's sort of how I took it.
Thank you. Eddie, did you want to add something?
Yeah, I just listened to Pam. That was interesting, Pam, your take on you were talking about the populations and how that was going to, because that goes back to the Milliman report when we were defining these populations. So I took it a different way. I was thinking when Roger was thinking about all the time we've spent since we started this, the bills that have been introduced to the legislature that we've been talking about, and things kind of move forward. So we've been talking a lot about transitional solutions that some are happening and some will happen potentially. I mean, the ledge just started up. There's one establishing medical loss ratios to 90% OIC. So these things keep going forward. We do talk about them, and they're part of our solutions and part of the grand plan. But yeah, we're not the only people working on this.
Thank you. Sarah.
Thank you. I've been striving to put my comments in the chat for reference later. I apologize if I could have submitted these thoughts before the meeting. I would have. I was unaware of that, but moving forward, I will not be shy in that aspect. I do want to think about downstream effects, and I think that is within our scope to look at the potential risks of whatever the larger commission would be giving to us, what I'm hearing is that we haven't really been given a whole lot, and we're kind of trying to guess what that is. And so I do support going back to the commission and asking specifically what they want for us to say, hey, if you move this direction, these are the potential impacts. Am I understanding that correctly, or am I off in that scope?
Giving this some thought. I think the commission is looking to FTAC for the financial expertise for the payment mechanisms. I mean, I think, I know it's a very broad ask to FTAC, and this is always, a difficult part of the process when it's a very broad question. You're trying to narrow it, especially things like provider reimbursement, which is I mean, I think Pam, it's one of our recent meetings. We had bullets on the, we had, bulleted lists, and Pam said something like, every single one of those bullets is huge. That's kind of been my mantra as we've been working on this work. Every single one of those bullets is huge. But I think the commission is looking to FTAC to narrow and come up with the recommendation. And so I think the work group will continue to put that together. And, I'm thinking about a few slides ago where we said, okay, the first time the commission's going to see this will be April. Um, and maybe that's not the way to do it. Maybe we pose some we, sorry, I'm thinking and talking at the same time, which is generally a bad idea. Maybe we talk to the commission, we get more feedback, we get more direction as the work group is also working on this proposal. One challenge of each entity, each body only meeting every other month is if you say, oh, well, we'll talk to the commission. Oh, and then we'll get it back to you. Well, months go by. So it would be good to have this work going on in parallel, but we also can get more information from the commission to send to FTAC, to share with FTAC between meetings.
I like that.
If that makes sense.
Yeah,
we try to keep people informed. Just to give you some background, we try to keep people informed between meetings, and also things like, circulating the draft guiding principles. People had an opportunity to weigh in and send us their comments to try to, incorporate that before the meeting. So anything we can do between meetings, moves things along pretty fast.
So I missed the boat on that one. I do have some. I see where that tension comes up in this group where we're saying, hey, somebody's like, we need to say something, we need to say yes to something so we can move forward. But I can see how if we don't figure out this one word, how it can impact things downstream. And so I could have submitted some things earlier to have that kind of presented to the whole group to hash out together. Is that what you're saying? Okay.
Yeah.
Thank you.
Thank you. I think the timing of when the email went out and when your membership was approved did not work quite well. So I think I think you and Hiroshi did not get that email, but obviously you'll be included on all the future things. Okay. So let us go on to the next slide. I'm keeping an eye on time here. We didn't talk as much about physician and other provider reimbursement when we were going through this in our last meeting. We talked quite a bit about hospitals. So looking at what we're calling transitional solutions for physicians, similar to reference-based pricing, begin with programs that cover public employees, then maybe expand, and also seek to rebalance the payments. This is what we talked about earlier. Increase funding for primary care and behavioral health. I felt as I was going through the recordings and the notes and everything else from the previous meeting, kind of felt like we did not necessarily get to a potential universal design recommendations or a timeline for providers. So I don't know if we need that. I don't know if anyone has any input on that. So I will open that up. And Bob, I don't know if your comment is about hospital or physician.
It's about physician.
Okay. Did you want to add something?
Yeah, so again, as an advocate, and you just mentioned before, this good to do things incrementally, and start with the public programs. So what I would recommend is with regard, and I agree with this principle, that you need to rebalance payments, but in the context of, I get it confused with Oregon, but you have PEB and SEB here, right? I would advocate that the Department of Health. Office of Healthcare Authority, whatever it's called, look at rebalancing payment rates to physicians initially in the context of that program, just as they've done with hospital caps, but along the lines of, and the recommendations out there that primary care physicians and other internists and so on are reimbursed inadequately relative to specialists, and that's a function of the Medicare process and the Utilization Review Committee, or the RUC, which is dominated by specialists. So there's a way of counteracting that by enacting those types of reforms in the context of the PEB and SEB programs.
Okay.
And so at least it'll take a look at that. It's similar to what was done with reference-based pricing with hospitals. Start small, make appropriate adjustments, evaluate them, and then take the next step. But that would be a good first step for the state. Now, quickly, I also just wanted to advocate that the state really augment its data collection capabilities with regard to non-hospital providers. I think you have two claims databases in the state. You should consolidate it and also figure out ways of collecting data directly from providers to not be preempted by ERISA, so that you can understand where there are discrepancies in payment for non-hospital providers, and even potentially make adjustments along the way. Because in Maryland, what we found is that once we went to global budgets, the hospitals, these are fixed global budgets, they shifted all their care out, and we had no way of tracking it. So having the data to be able to track this and evaluate payment inequity and make adjustments is very important to have going down the road, because you really are flying blind at this point, except for this general point about, primary care, nurse practitioners and so on are under reimbursed relative to specialists who are over reimbursed. But I think you can attack that issue in the context of PEB and SEB early on.
Thank you. And Roger.
I'm going to reach a little further than Bob. I do really need to start somewhere. And when we're thinking of PEB SIB, I would suggest we give thought to one, including the Medicaid programs, which is bigger than either PEB or SIB. And the issues we're dealing with, even though it'll be at a lower level, this rebalancing, for example, equally apply there in most cases. And also to the extent, Pam, I like this one, to the extent that there's the public option, which is essentially what the state is controlling in its structure with the exchange, should be considered in those set of discussions. And then so when we're thinking about this issue of sequencing, when we talk about state purchasing, we ought to include as big a bundle as we can. Again, Medicaid, SEB, PEB, and the exchange. And then I have a question, and I should know this, but in our all-payer claims database, we get payment amounts, for example, primary care, I'm just using that we get what the plan or whoever it is paying to providers, right? I mean, that's kind of the no-brainer. I just want to reaffirm that. My point is that I think to Bob's point about getting a picture, my understanding, if it's maybe incorrect, is that we can get that picture from the all payer claims database to see some of that phenomena.
Could I just make a point there, Roger, very quickly? From my knowledge, you have two all-payer claims databases, and they're not merged.
Well, actually, why don't we bump this to Harrison, because he is the cost board APCD guy. Harrison, do you
I don't
know
know
the
if I would
answer
go
to
that
this?
far.
Okay.
But yeah, Roger, if I'm tracking your question correctly, the answer is yes. But there's also tracking of the co-pays from patients as well.
Yeah.
So,
But Harrison, correct me if I'm wrong. I mean, you don't necessarily get all the data from the self-funded plans, because in other states that has been ruled to be preempted by ERISA.
Ross is probably the best one to answer that question. We've been through that actually quite recently, but I believe self-funded plans actually are included for the most part, with some asterisks and exceptions.
Yeah, we do have quite extensive reporting on self-funded, much more than I had thought too. I was anticipating having limited. That comes through carriers, functioning as TPAs that report to us, as well as provider organizations. I wouldn't go so far as to say we have 100%, but I do think we have a substantial amount of self-funded claims that we have through our APCD.
Yeah, well, so my point is just to make sure you expand your data collection as much as you can to get all providers. And instead of, if you're potentially going to be preempted by ERISA, you could pass legislation to collect that data directly from providers. as something to do. I was also told, and again, I'm ignorant about this, but I was told that there are two APCDs. There was ones that an alliance put together, and there's also the state APCD, and the two don't overlap. So it just seemed my point is, get one comprehensive database however you can, because you're going to need that for this element of the proposal.
And don't forget about the hospital associations too. They have their own data that they use. So data standardization, I support and echo all of that, what you say, Bob. We need to get that in one funnel. And to the self-pay, I'm sorry, I am a bit of an expert in some of this, so I don't want to be over my skis at all on it, but what I do know, struggling with it, blood, sweat, and tears to get my dissertation done, I know that the self-pay is a voluntary situation, so it sounds like we have good voluntold individuals that are playing the game, but definitely getting that in legislation or memorialized would be awesome. So
yeah, and again, I don't think, sorry to belabor this, I don't think you can mandate legally, so you have to rely on the voluntary, but you could mandate legally to collect the data directly from providers. That is not preempted by ERISA.
Well, why don't we can go to the legislator, Bob, and we can make that happen, right?
Yeah, right.
Yeah,
So you should
right.
consider that to complete the database. There's also this issue of two databases, which I just was told about, but it seems like it'd be better, obviously, to consolidate the two and then augment it by collecting data from the payers or from the providers directly. But that's my recommendation.
And just wanted to highlight too, Bob, to your point of a different way of getting this information. There's a bill that was passed last year establishing a healthcare entity provider registry. A different way of kind of collecting information and kind of a different route. It was pioneered by Massachusetts Health Policy Commission. We haven't been funded for the actual registry yet, but kind of a series of reports that would kind of provide the parameters for it, how it would be funded. But that seems like another unique opportunity to be able to get some of this information that we might not otherwise be able to get through the APCD.
Yeah, and I just say it's good that you got a lot of, spirited people in the self-funded industry that are doing this voluntarily. All it takes is one challenge, though, and it will ice you out from getting all the self-paid data. So that's why getting it directly from the providers is an important fallback.
Thank you.
And yeah, Roger, is this about the physician? Because I want to move us along to incentives and get us to our break, which we all need.
Just one last thing, Ross,
Okay.
I forgot the gentleman who is your data gentleman. He did the presentation with the commission.
Vishal.
Vishal, our chief data officer.
So could we get from him, because this would be helpful. One is, what's in and what's out. And as go back to kind of this one what Bob said, we got these separate systems. I'm quite frankly, I'm confused now. It'd be helpful just to say what is it we're getting each of those. One small example, and I'm going to get this back afterwards. We do get, I believe it's Part C Medicare data, but we're not getting the Medicare fee for service.
No, you have that's a public database. You have that. I don't know if it's specifically
What?
your APCD, Medicare fee for service. That's
It's
public.
public?
Yeah, it's available. So you could integrate it into your APCD.
Well, one of them we're not getting. I'll just say that we have to go a long strategy to go through CMS to get it. So it's not just out there to grab.
Well, I know, and maybe
it's not out
whatever,
there
but it's likely part of your APCD. Maybe Pam knows about this. I was told that there are two different databases in the state, and they were going to be merged, but then they took different paths. So I don't know all the dynamics associated with that, but that's an issue that we might want to deal with.
I know more about this than I would ever want to share with the group. I was involved with it for years. And I would almost recommend that we not go down the rabbit hole of trying to parse the data and understand it all ourselves. But I think we could come quickly to a general recommendation about what we want from a data system and what we advise the state to do.
Right. Yeah, I agree.
Great. Thank you.
Right.
And to your point, Roger, I think we probably could get a document or something that maybe lays out what's collected through the APCD for reference to this group, and love Pam's recommendation of focusing on what we hope to get out of it, and then can maybe do a justification with what we have in there. So that's something staff can work on bringing back to FTAC.
Could I make one just quick point about physician reimbursement I didn't raise. It actually straddles both hospital and physician. One area of rate setting that I think is very important that gets overlooked is the hospital-based physicians, the radiologists, anesthesiologists, pathologists, emergency room docs, and to a certain extent hospitalists. They have franchise monopolies at hospitals, and they charge exorbitant rates in general. And so when you're talking about hospital rate setting, this straddles both sets of providers. There should be some sort of limits placed on the ability of these monopolies to charge monopoly prices for those services. And these are, oftentimes the patient comes in, doesn't even know that they're being serviced by this group, and this group then gouges them in their prices. It's part of what stimulated the No Surprises Act. But regulating those prices, I think, are important as well. And it's kind of,
Okay.
Anyway, I wanted to throw that out there.
Thank you. Okay, I'm going to go through, thank you all. I'm going to go through the last two pretty quickly so we can take a break. Takina, oh, there we go. Thank you. Before I even asked. These are some of the incentives that came up in conversation about provider participation incentives. They could have administrative simplification. They could have one process, predictable funding. I don't know if there's other things we want to add in there. I think in the interest of time, we may just circulate that question via email, ask for input on that. And I'm going to go to the next slide, which is our next steps. And we have our work group. Thank you again to our work group members. You're going to be hearing from us because we need to gather again. We need to gather all this information. Staff is going to incorporate the feedback, create the next draft. The work group's going to kick it around the room, and we will figure out what makes sense. The hope is that in the month of February, there will be a revised draft or initial draft to be circulated among FTAP members for comment. When that email shows up, feedback at that point would be great because then we can keep moving it forward before the March FTAC meeting. We can get a lot of things hashed out and revised before the March FTAC meeting. And I think what's not on here, but what we heard today is maybe bringing this up a bit to the commission at its February meeting. Pam, welcome to your liaison role. We will work together to figure out how we want to take this to the commission and what questions we want to ask. So those are our next steps, and I think that is the end of this section. Ross, I think that takes us to a break.
Yes. And I know for our new members, I know Hiroshi had to step off, and Sarah, maybe we can see if they're interested in participating in the work groups as well, unless that was already okay. Excellent. Yes, and I get the joy of saying that we get to go on a break here. Mary, we had originally contemplated a 10-minute break. We're about 5 minutes behind. I say we give folks till 4, but I'm willing please overrule me if you
No,
think.
I think that's fine. That's fine.
Okay.
All right, because we only have one more topic after the break.
Excellent. Well, see you at 4 p.m. And we will be discussing possible questions to utilize the funding we received from OIC to do an actuarial or economic analysis to kind of study universal benefit design. So exciting discussion after the break.
See you all in 10 minutes.
Ross, nice job herding the cats.
I have to admit, it makes me really happy because it means that people are interested. I've been in the other position where you're begging people to give ideas. So if we had the luxury of longer meetings, I think we could let that run, indefinitely. But yeah, sometimes just for sake of time. But I love it, and thank you, Sarah, for all your contributions. Just joining, did great work. Welcome back, all. We have hit 4 o'clock. Those breaks seem to go by very quickly, don't they? Um, if folks would be willing to turn to page tab 7 in your packets. Like I mentioned, we're going to do some discussion regarding possible analyses that we could do with our OSC proviso funding, and I'm going to turn it over to one of our senior policy analysts, Jen Scott, to walk us through it.
Hi, thanks, Ross. I've been a policy analyst with the Cost Board for a little bit over a year, and I'm going to be helping out with the Commission and FTAC this year, and um, playing kind of a project management role with the OIC proviso. So I'm just going to provide some background information to remind folks what this is, and then get into a discussion with the goal of pulling together some recommendations for the Commission. So just the overview, this is $250,000 of the Insurance Commissioner's regulatory account. And it's provided for the commissioner to enter an agreement with HCA to support economic, actuarial, or other modeling related to the design of a universal healthcare system. And the funds need to be spent by June 30th, 2027. Next slide, please. And the final deliverable will be to provide guidance for making a recommendation, not the recommendation itself. And the focus will be on one of the outstanding design elements, so the ones that are listed here. So eligibility and benefits and services are not for consideration at this point. And just a reminder, it's economic, actuarial, or other modeling. Next slide, please. So we wanted to focus the discussion primarily on which of the outstanding design elements should this work focus on? And then also, what questions specifically would we want to answer? Does the group see the focus and progress of this work impacting timelines related to the other universal design elements? Kind of, are there contingencies between this work and progress on the other areas? And then another question of how do we determine if a topic is too far out of scope for designing a universal system? So I think if we could go back one slide, we could just kick it off with the first question. What are the group's thoughts about the design elements that this work should focus on?
Ken, do you mind if I just really quickly provide a few additional background items? Yeah. Thank you, Jen. Just judging on our last analysis that we did, it took, correct me if I'm wrong, Mary, 9 to 12 months roughly from initiation, the contracting part, working with the contractor and going back and forth, and then finally getting the ultimate analysis. So just in terms of timeline, if that factors into any of your decisions, it was approximately 9 to 12 months. And we had also, for the last iteration, formed a work group that assisted with, as the project kind of initiated with the contractor, going back and forth, asking technical questions, providing technical support to the commission, and kind of working through any questions that come back from the actuary. So that's also a key component of this, and I'm sure will be discussed later, but just want you to have that information as you're thinking of questions and topics. Sorry, Jen, back to you.
Oh, Jen, I also wanted to throw in something, if I may. This is just lessons learned from our experience with the Milliman actuarial project that was completed last year. There's the project management, there's, executing the agreement. There's probably also going to be a data share agreement. And that's part of the timeline that Ross mentioned. It's, it just takes time. It took a little longer than we anticipated for Milliman. It took us a few tries to get the data share agreement right where we wanted it. And I'll just mention something that was on the previous slide that Jen highlighted, which is the work of this proviso, the work that it pays for, is intended to inform a decision, not be the decision. And Milliman's a very good example of that because they were modeling the costs of various benefit designs for various populations. And Milliman didn't say, we think this is what you should recommend, but the commission looked at the results and said, oh, we think this is what we should recommend. They used the information to inform the decision. Just wanted to offer that extra bit of framing.
Yeah, thanks, Mary. Thanks, Ross.
Mary, can I just real quickly again, can you go through that one more time again for this? It was in that other slide, just so I'm a little confused.
Oh, which part, Roger?
Can we back up that one last slide?
Sure.
Not the recommendation. So what can you give an example? I'm not quite sure I understand.
Oh, Milliman,
Yeah.
they modeled, the cost of different benefit packages.
Mm-hmm.
The commission then basically said, okay, we think we should, pretty much go with PEPSEB. But Milliman didn't say that. Milliman said, here's the dollar amount.
Yeah.
The commission said, here's where we're going.
I got it. Thank you. I'm sorry. I got it. Got it.
No worries.
Thank you.
All right, so maybe we could think about the first two make sense in terms of the design element and what the question would be to consider. Does anyone have any thoughts?
Sorry, I just have another clarifying question about this. So, I take it that Milliman would be doing this work, and then if we go to the previous slide, some of the things on that slide didn't seem like actuarial topics to me. So, or is it there an open question who the contractor would be? So, for example, governance is something I wouldn't have thought was in scope for an actuarial firm, but I'm not totally sure. I just want to get a sense of what the services are that can be provided.
Yeah. It's an open question who the contractor will be. We tend to talk about the Milliman example because that's what we did last time, and it was an actuarial question. The wording of the proviso is pretty broad, which is why we keep putting it in boldface and repeating it. Economic, actuarial, or other modeling. So the or other, I think, gives quite a bit of leeway. And again, obviously, we don't have complete carte blanche because the Office of the Insurance Commissioner has to agree that this is the appropriate direction to be heading.
And Christine, you raised a good point that maybe some of these future design elements like infrastructure and governance don't lend themselves as well to economic or actuarial modeling as some of the other topics. So that is probably something to take into consideration when we're articulating questions. Great point.
Matthew?
I'll just throw an idea out there as someone with probably the least amount of healthcare knowledge on this panel, but an issue that I'm just curious about. I don't know much about it, but this idea of global hospital budgets and having stabilizing hospitals at a very base level. And, how much would that cost? How would it be designed with the right incentives and the right cost structure and all that? I don't know if that's the type of thing the type of study or information that you're looking for that this is intended to do. But that's where my curiosity is. And it is a curiosity because I don't know anything about it. But from what little I've learned, stabilizing these hospitals helps every part of the state. It's a discrete area that can be kind of a stepping stone toward universal healthcare without having to do the whole thing at once. So it just seems like having some numbers around that or understanding what different models are for places that have done it I don't know how many states or maybe even cities or counties have done it. But just finding that out and what the experience of other places have been who have tried it or gotten part of the way there. That's what I would be curious to learn.
Okay.
Thank you. Roger?
Yeah, this is kind of a direct response to Matthew's. We do have some Washington specific information from a study that was done under the direction of the legislature by the Office of Finance, I'm sorry, the Office of Insurance Commissioner that looked at five, if you will, affordability items. One of those was global budgeting. They also included just whatever else that's worth reinsurance, medical loss ratios, reference-based pricing, which has been implemented, global budgeting, and something on a benchmark growth one. So they've done some looking at that Washington specific that might serve as background material for our deliberations. And I think, Mary, you guys have access to all those reports, right? Right, and I can get them for us if we need them.
Yep. Thank you.
Okay. Can I add one thing about modeling that's going to be a challenge? And when I think about modeling, I'm just kind of referencing back to the work that HMA did for that report. I mean, they essentially took a system in place, part of Washington's system, and tried to do some analysis based on a given our systems that are in place today. And since we don't have a model in place yet that says, here's what the new health reform system would look like, right? We've talked about this in the past. We're not going to be able to do that now. To model the impact of various payment options under that new system, we're not going to be able to do because we don't have a base model to work from. So that any of the modeling we do would be, what is in place today for our given systems, and if we're looking at some of these payment options, they would be kind of a transitional step. Like for an example, what if you adopted global budgeting for SEB-PEB, but it would not be for the new system, if I'm making sense.
Sorry, Roger. Thank you. And I'm also reading things in the chat. Sarah, did you want to make a comment? I mean, I'm looking at your comment.
Sure, I'm trying to because it's so easy to go down so many rabbit holes, and I'm trying to focus so many things I would love to do with that money. So I just wanted to make sure I clarified in the chat. This is my understanding of what we've done so far, because I am a newbie coming in. And then now we have an opportunity to move some of that work forward in this way. So what did I say? Well, you guys just I don't need to rehash. You guys have all been here. So that the Milliman report, are we able to take like what they've suggested? And I'm saying, like, how do these models behave when they meet real services? So like, can we take real data and pull those through to see what they would look like, and be retrospectively? I mean, it sounds like their numbers were from 2023, so we'd maybe stick with that for continuity. Are you following what I'm saying here?
Yep.
Okay. I mean, these are my rolling thoughts. Right. So okay. I apologize. I can send an email with more complete thoughts once I get there.
Okay. Thank you. I also want to bring us back to the very, very beginning of the meeting. One of our public comments was about, use this money to look at a piece of financing, something to do with the financing design component. I don't know if that, if anyone has ideas in that regard to add to this.
I wonder, might it be helpful if we're just going off the first question that is asking us to look at the outstanding design elements to maybe go back to that previous slide that listed the outstanding design elements, maybe treat it as a multiple choice question.
I just feel like they're sort of interrelated. I mean, the previous work that we did looked at the cost. If I'm remembering this correctly, it looked at the cost of various benefit design packages, right? So it looked at if you had a silver plan on the market, something equivalent to silver plan, something equivalent to employer plan, and it gave us sort of the sense of what the cost would be to the state. There must have been an assumption underlying that about provider reimbursement. And that's a lever that I don't think was explored in that analysis, right? So those costs might look different. And then that, depending on how we structure reimbursement. And then the financing is sort of dependent, I think, on what we come up with the cost. Like, are we having an increase in cost? Are we having a reduction in cost? So it seems like maybe this is sequential and that the next logical step would be to almost even marry that previous analysis, which I don't have, like, it's not at the top of my head, so I might be wrong about exactly what it looked like, but with something on how would this vary across different reimbursement frameworks, and then that can then take us to financing.
Pam?
Yeah, I liked what Christine had said just now, and also earlier about maybe infrastructure and governance aren't very helpful on this list, that they belong on other lists. And then I feel like we've sort of avoided talking about financing because it was something we could do later, and also it's a really, really hard topic to take on. But it is kind of a core value of this group. So I think that when we looked at provider reimbursement on those other groups, Christine, I'm not sure either, but I think we kind of looked at kind of status quo provider reimbursement. So kind of hold things steady so we could, compare across. So one of the things we've talked about with global budgeting and other issues related to a more universal system is we can't afford the system we have now. So are there things we can do to be more aggressive in cost containment that would make a difference? And that would be something that would be very interesting to model. I'm not, that's bigger than I could figure out, but maybe we could even get help kind of breaking down the question and thinking about how to ask that and model it.
Yeah, thank you, Pam. And Roger,
Yeah.
Roger and Sarah, I see your hands, but I just want to jump in. Something to do with cost containment. Cost containment was called out as a separate element, and it used to be in our list, our list where things turn that lovely shade of green when we get our proposals done. In the past year, we decided, you know what, cost containment actually kind of belongs everywhere. It's not its own thing. It gets woven into everything. So, Pam, I'm really happy you just mentioned that because really it should be on this list. Our oversight not to put it in there. Sorry about that. But yes, let's mentally add cost containment to this list. I don't know if that changes anybody's impressions or answers. Roger.
Yeah, this is a technical response. For the Milliman analysis, for folks who are familiar with it, we looked at three benefit designs: Medicaid, UMP Classic, and the Silver Plan, essential health benefits in Washington. And for the pricing on that, Milliman used a weighted composite average of all of those three reimbursement pieces. So you had three separate reimbursement systems weighted by the number of persons that would be in the system. So it's kind of, if you think of a weighted composite, that's the price structure they used to compare those three benefit designs.
Thank you.
I'm probably not making it any clearer than it should be.
No, that makes sense. I was trying to remember the details, Roger. I'm thinking, okay, I'm going to go dig back into that report to remember. It was almost a year ago, but yeah, I think that's correct, and we can dig into that and get information to people on it if you're interested.
Yeah. So one more time, and I'll shut up my time. One of the things maybe on the financing side, just food for thought. Given that we don't know how much we need to finance, But what would be maybe useful is to go through for Washington and all of the revenue or tax systems we have in place today. And the Department of Revenue can give us this, kind of a summary of each of those, the dollars that are being collected so you get kind of a sizing of it. And then to ask, let's say, if consultants, whoever is to say, well, what are other states looking at as a way of financing the new system? And of course, that leads us down, employer payroll taxes to deal with ERISA, but there's a variety of those. So what I'm suggesting is what could be a sort of a detailed laundry list of financing options that, the commission, ourselves could consider in the future.
Thank you.
So, Roger, would that look sort of like testing out those different options through the analysis that would then inform the recommendations on financing FTAC would make to the commission? With that, is how
Yeah.
that process would work, or would those ideas be on financing be fleshed out before sending for analysis to an external contractor?
That's a great question. And I guess my first thought would be is you have a laundry list of what's out there. And I just one example with it. We don't think we have a carrier tax, 2% on carriers. And that's used to finance a lot of healthcare stuff. So that's one. I'm just making up. We got a B&O tax, all over the place, and you can target B&O taxes to the provider community, this or that. So I guess at the point of kind of having that list, so we can see what is existing in place that we could call upon for the future, and a different cut at that also might be is what are other states using to finance their healthcare area, like expanding Medicaid or this or that. And the third one is that when we talk about, moving towards healthcare reform, our usual conversation, we can't get at ERISA, right? We've had this conversation before, but oh, come on. Our folks from back east, Burns and McCluskey, gave a great deal on saying, here are strategies that you can use, we think, to implement a payroll tax to try to deal with the ERISA preemption issue that we think would avoid an ERISA challenge. So it's trying to kind of put all that together in a, if you will, a catalog of, if you will, financing options. Now the problem with that, Ross, otherwise you can say, well, how can we test those out? Well, we don't have a basis now to test it out. So I'm not sure I hear what you're asking. I'm not sure quite how we would do that, unless again we had a model in place that we could implement. But at least it would give an array of options for the commission to consider.
Okay, thank you, Roger. That's where I was too, is trying to solve for that missing piece of information.
I think Sarah had her hand up next.
I'm putting things in the chat. I just was trying, I feel, I apologize if this stuff has already been hashed out a little bit, but being a newbie might be a good perspective to come in. It's like, so what I hear happening is that we don't know what we're trying to meet. I hear universal healthcare, and I hear that we want to take the current system that we have and maintain that, but we currently are operating from the Milliman report that the costs have gone up 6.2% in 2023. So we don't know what 2024, 2025 has. And the cost board has said our goal is 3.2%. And so we're trying to, we need to ask somebody to tell us, how do we do this? Like with the data we have. And we haven't really defined what that is besides through cost. And I'm more interested in, I think residents, constituents are more interested in services or health outcomes, and we haven't talked about anything besides cost. So has there been any talk about what we're trying to maintain or what we're trying to commit to in this exercise of universal healthcare?
Yeah, I think you might be asking about benefits and services as opposed to the payment mechanism. And benefits and services is a proposal that the commission approved last year. I don't know precisely when. Let's just say 2025 and call that good enough. And that was informed by the Milliman analysis of, what looking at what the costs might be for different benefit packages. And they decided it would be based or, trying to mirror what is currently offered for public employee benefits and school employee, PEBSEB, public and school employee benefits, that body of benefits and services.
The UMP plan, I
Right.
believe
Yeah.
specifically. Yes.
Thank you.
Thank you. That is helpful. UMP plan. That gives me something to wrap my brain around. Thank you.
And we can send you that analysis
We can send
too.
you that.
But yeah, that's sort of the baseline that the Milliman analysis at least is working off of.
Okay, thank you.
Matthew?
First, I wanted to answer Roger's question from the perspective of the Department of Revenue. We have for the past 2 years been trying to find new revenue everywhere and with all sorts of crazy ideas. And we have had to shoot down many of them because they're unworkable. The most direct way to raise revenue is to raise rates on whatever tax it is instead of coming up with some. Everyone thinks they have a clever new tax until you go at it and it creates the wrong incentives and it'll actually reduce that revenue. So I think spending money on a study to study that would be a waste of the money. I earlier talked about my curiosity regarding the hospital global budget. My other idea, just from a revenue standpoint, my curiosity as I delve into this problem is what would it take? What incentives would private businesses need to voluntarily move to a universal system that we start one up, but it's voluntary at first? And we say, instead of sending your premiums to Aetna or Kaiser, send your premiums here and we will cover your employees. And what incentive, what would businesses think of that? Have they been confronted with that choice before? How do they decide to choose the actuarial decisions that would go into, do we shift, trying to pick a medium-sized company, medium-sized company X, and they send, how many ever $1 million a year to United Healthcare. What incentives would get for them to take? I assume it'd be they get the same healthcare for $1 million from the new universal plan, whatever that is. But just some research into the incentives that businesses face, because we're talking about funding the plan, and people automatically go to the tax dollars. The tax dollars aren't there, and it's going to have to come from private funds. And if we're going to have a gradual transition to this new system, what would it take to incentivize businesses to come over a few years at a, spread out over 10 years to come into a universal system? I don't know if I stated that correctly. You're welcome to ask a question if I didn't state that clearly.
Roger?
Yeah, Mate, that's a great question. And one response would be is states that have looked at how do we get particularly large employers in ERISA who we cannot bring into this new system, how do we induce incentives to have them move to the new system? And the strategies that most other states have wrestled with and are various strategies around an employee payroll. It's a payroll tax. And then, the underlying, and there's various strategies doing that. But the underlying notion is you're providing health care today as a benefit. We're going to be taxing you X amount, and that money is going into a pool to finance universal health care coverage. So rather than double paying, stop providing, health insurance as employee benefit, do something else with it because you're already paying a payroll tax to finance it. So that's kind of the approach that states have been considering. And again, to go back, there's some ERISA strategies around having to do that in a way that don't necessarily evoke an ERISA challenge. Is that?
I just throw it out there as a research topic.
Yeah, no, it's a good one. It's a great one.
One clarifying question for Matthew or for anyone. To get to that kind of threshold or target at which entities would move away from a self-funded this universal benefit, would that, I imagine that would need to do a survey of some sort with, small, medium, large size, to figure out where that threshold is. Is that right? I'm just trying to think what would fall under the umbrella of the modeling, actuarial analysis, and what might be done separately. If anyone has any suggestions or idea how that might be completed.
I think there's probably a combination of both, some modeling of typical businesses and how much they spend on healthcare, but also some surveying. But I know surveying probably increases the costs significantly if you're calling individual businesses and getting them to try to share information. So that's I guess for whoever does the study, for them to figure out the best way and the most cost-effective way to do this. But that exhausts my knowledge on that subject completely.
Thank you. Christine, please.
Thanks. And I know we're out of time. I don't know if we talked about this as a transitional step, this idea of having employers kind of voluntarily go in, but I do want to raise that, like, as soon as you make it universal coverage, it can't be voluntary. Like, the employer has to be mandated, or else you lose that revenue because they'll just drop it and the state will be covering the beneficiary. So I just want to raise that this may be a really interesting idea to consider, but it introduces a new angle of like the transition plan that I don't think we've previously thought through.
That's great. Thank you, Christine, for mentioning that. Yeah, this is such a difficult topic, trying to figure out an analysis here when we're, roughly halfway through the design elements and how to model those while not getting out of ourselves. So thank you. I'll hand it back to Jen.
So I guess I would ask Mary, what do you think the next steps are?
Yeah, unfortunately, we have run out of time. Thank you, everybody. I I would love to keep hearing everybody's ideas because I think, we put these up on the slides, we put these in the packet, but this is maybe something that folks need to sit with and chew on a bit to come up with ideas. So if it's okay with you, I think maybe we will just ping you on this one between now now and the next meeting, or now in the commission meeting, and try to get further input on all of this. We did hear some ideas that we can take to the commission, and also, would love to hear more ideas as people give this some more thought, because this is one you have to sit with. It's not a quick answer.
And perhaps, Mary, I'm wondering if it'd be helpful to FTAC if we were able to get the commission to identify maybe which one or two of the design elements they're hoping for, and maybe that would refine kind of the scope of our of this search for the right question. So maybe that's, along with the discussion we had here, we could try and get them to identify what design element they'd like this analysis to focus on.
Yeah, and again, that's not something that has to wait until the next commission meeting. We have email. We can reach out to the commission and try to get their input as well, and give them a little time to chew on it and think about it. All right, I think we are at our end, Ross.
Okay. I really want to thank everyone. Again, I so appreciate the discussions and discourse and back and forth. It is really invigorating and appreciate everyone's energy and investment in this work. Our next meeting is going to be March 19th from 2 to 4:30. We look forward to seeing you there. And this meeting is officially adjourned at 4:34. Takina, if you could please stop the recording.